I believe it was just last month, about home safety. So the reason we talked about home safety is because that's how you stay out of the hospital. So there was a lot of crossover, so I made the topic a little more broad so that it wouldn't be exactly the same thing that we've talked about in the past. Because I think in the old days, going to the hospital was sort of like the thing you did when you're sick. And now I routinely say to my patients, let's do X, Y, and Z because I know you don't want to go back to the hospital. So there's clearly been a shift in how we perceive the hospital and what its place is in our care. Also, what Adina was alluding to was what Medicare has done over the past several years in order to encourage hospitals to provide better care. So we're going to talk about that soon. So everybody just make sure they're muted. Definitely unmute if you have something to say, or you can enter it into the chat on the GoToMeeting drop-down menu. Thanks so much. Okay, so how do we reduce hospitalization? So if everybody closed their eyes and didn't look at this slide, it would be super easy to come up with a list. I've made a list of 5 things. I'm pretty sure it includes everything. If everyone follows these rules, they're not going to the hospital. Easy, right? Everybody needs to keep their doctor appointments. You need to take your medications exactly how they're ordered. You need to report any new symptoms right away. You need to eat healthy and you need to exercise. So this is a short list. I really think it includes all of the main things that our caregivers are going to be addressing and they're present for in the home. These are all things that they can be supportive for. And definitely, while I'm joking, it's not really easy, but these are things that anyone can learn, and it's not a complex set of rules. So keeping a doctor's appointment. So that means routine visits, preventative medicine, all the things that everybody hates to do. I went to the dentist yesterday. Nobody likes to go to the dentist. But when I left the dentist, I made an appointment so that I can go in 6 months. So now I know that I'm being responsible for that part of my body, even though it's absolutely no fun. Taking a medication as ordered, I'm sure even personally people have, it's hard to follow this rule, but certainly for our clients who are probably taking maybe 10 or 15 pills at a time, they're going to look at their pills and they're going to say, well, I took all these pills yesterday, I still feel the same, let me take one less today, what's it going to hurt? And that, of course, can be really dangerous. I think, and we're going to talk later about medication reconciliation, but when people feel like they're taking too many pills, there are other things we can do besides not taking those pills. Can everyone just mute? I think someone else maybe unmuted their sound, please. Thank you so much. And another thing is about reporting new symptoms. So I'm sure we've discussed this before, but our clients and older people in general, they can really be fearful of reporting new symptoms to their doctor, to their family, because they're afraid of what it's going to mean, of what they're going to find out, of what's going to happen next, of a new diagnosis, of a new medication. So our caregivers really need to watch. They need to watch that there's nothing new going on with the clients. And if there is, they need to report it to us or report it to the facility. Because I always tell my clients, small problems are easy fixes, and big problems may not be. So whenever there's a small issue, while they may feel like they're complaining or they're being nitpicky, if we address it right away, if it is something, then we can certainly take care of it while it's a small issue and not have to be concerned about becoming something bigger. And number 4 I have is eat healthy. So for clients on a diet for low sugar or low salt or a fluid restriction, this is again something our caregiver is going to work at supporting our clients. Eating healthy, our caregivers very often are the ones cooking the food. They may even be the ones shopping for the food. They have a tremendous role in really influencing how the client eats. And then exercise, of course, is according to what the client can tolerate. I saw a client last week who has a primary diagnosis of a disease that causes a lot of fatigue and weakness. So every time she has a new caregiver, the caregiver calls us and says, oh my gosh, Mrs. So-and-so, she's so tired, she's so weak, what should we do? So I went to see her the other day, and I said to her, you have this diagnosis, it's going to make you tired and weak. But here are some ideas that we can do together, you can do with your caregiver, so we can do the best we can with the diagnosis that you have. So I suggested to her certain tricks for eating a little more frequently a day, certain types of foods that are higher quality, and then I suggested some very small exercises. And she says to me, oh, everybody says the same thing. So clearly, everybody she's made this complaint to has given her the same advice. She, for whatever reason, has chosen not to, or feels she cannot follow this advice. But these are the gold standard. So this is the way we reduce hospitalization. So we've only been talking for 10 minutes. We could really be finished. Wouldn't that be great? No, I'm just kidding. So these are the things that we want to really impart on our caregivers and our clients' families on the gold standard of how we can do simple things and make small changes in order to reduce hospitalizations. So hospitalizations and the problems that we have in the hospital represent just a significant problem for our clients. The elderly population represents 12.5% of the total U.S. population. So it's a good percentage that is absolutely increasing. It's going to increase by 20% in the year 2030. So we're looking at 72 million elderly people, which are the clients that we service. It's a significant part of the population. So it's important that we focus on their needs because they are such a significant part of the population. So by 2050, 1 in 8 Americans are going to be 75 years or older, and I apologize for the statistic. It's from 2002. I had a lot of trouble finding very, very recent statistics, but I'm sure we can imagine it's only increased since then. But in that year, the elderly accounted for 12.7 million, which is 41%, of the hospitalizations in the United States. So in that year, 41% of all hospitalizations were people who were elderly. So clearly this is a significant concern for us and our clients. It's estimated that almost half of adults, like we said, 41%, who are hospitalized are 65 years or older, even though those people who are 65 years or older represent significantly less than 41% of the population. So here they are, they're the smaller part of the population, less than 15%, yet they're representing almost half of all people who are hospitalized. And of course, this is going to only continue to rise as older people are living to be even older and as medical technologies advance and we enable people to even live to be older ages than they have in the past. The average hospital length of stay, so back in the old days, you know, in 1990, so that was already a long time ago, the average length of hospital stay was almost 9 days. And it's decreased to 5 days. So people are staying in the hospital for much shorter times than they did only a couple of years ago, 20 years ago, 20, 30 years ago. And of course, they are coming home sicker, which is significant for us because, of course, we're the ones taking care of them. So shorter lengths of stay highlight how important it is that the care needs, the needs of the client, be assessed and be determined during the hospitalization. Because, of course, if their needs are not determined during the hospitalization, when they come home, we're going to be starting from scratch. And ideally, their needs should be determined before they leave the hospital. But, of course, we all know, everybody who works with caring people know that when people come out of the hospital, they very often come home with little or no support. So now it's great that they have a caring people aid, but what about the other services that they need or the other services that they're entitled to through their insurance? Have those things been taken care of? And now how is that going to affect them possibly going back to the hospital? So when elderly people are hospitalized, they're at a high risk for what's called a functional decline, and that's because they're not moving around as much. So we've all heard the story. The client is basically independent. She falls and breaks her hip. She goes to the hospital. She comes home. She's never the same. The hip heals, but the rest of her is never the same. Why does that happen? So the elderly are especially at risk for problems during their hospitalization, which of course contributes now to their change in status that we're seeing when they come home. And part of the things that they are challenged with is falls, delirium, infections that are happening in the hospital, problems with their medications, and of course bed sores or pressure ulcers. So why do people go to the hospital? The most popular or the most significant diagnosis that people go to the hospital for is heart failure. Heart failure is a disease that we see very often in our clients. It affects the lungs, and it affects the fluid balance in the body, making it sometimes difficult for them to breathe. These are the clients that are going to need daily weights. Some of them have fluid restrictions. They're going to be on breathing medications, and this is a chronic disease that is going to get progressively worse. There were 1 million hospitalizations for congestive heart failure in 2010. It's the #1 reason for hospitalization for people over the age of 65. Another reason why people go to the hospital is because of medications. So what's going on? Improper use of medications and use of illicit drugs can result in hospitalizations in the elderly. Usually when the elderly are hospitalized for a problem with a med, it's because they've overdosed or taken too much medication for pain, usually by accident or because they don't understand or because the medicine is not working or because they've decided to stop taking medication and now they're experiencing symptoms of withdrawal from other medications that might be addictive or sleeping pills which can't be stopped abruptly. Another reason why people end up going to the hospital is because of immobility. So lack of physical activity can lead to more visits to the doctor, more hospitalizations, more use of medications, which will put them at higher risk now for being hospitalized. Falls is definitely significant to our clients. 30 to 40% of elderly people living in the community fall every year. 2.5 million people are treated every year in the hospital and in the ERs because they've fallen. And more than 700,000 patients a year are hospitalized for falls, and it's usually because of a head injury or a hip fracture. When a younger person falls, they've got all these things working for them. They've got quick reflexes, they've got strong muscles, they may never hit the floor, they may fall and brace themselves with their wrists, their bones are strong, the bones don't break, and it's no big deal. Tripping and falling, I mean, what is that? It's no big deal. In older people, it could be a tragedy. So if you're looking at my screen, this is a pie graph that talks about who goes to the hospital for heart failure. So these 2 years that we're looking at here are 2000 and 2010. What's interesting is that the number of hospitalizations did not change in those 10 years, but if you'll take a look, the age group that ended up in the hospital did change significantly. So clearly we're looking at a shift. It is still the most significant diagnosis that people go to the hospital for, and even though we're not focusing on it, it is a very, very common reason that people are re-hospitalized. So, of course, another reason people go to the hospital is because of hip fractures. More than 250,000 people are hospitalized for hip fractures. Heart attack, very significant, and stroke. So the rate of hospitalization for stroke, it has increased over the last many years, and it continues to increase. And of course, more than 2/3 of those hospitalized were for patients 65 years and older. So this is another graph that shows how significant it is for our population, and the groups of people that we very often treat, and those age groups are at very high risk for being hospitalized for stroke. And this is the unintentional fall death rate for ages over 65. So you can see the graph starts in 2004, and the death, and it goes till 2013. And of course, there is quite a significant increase. We talk about people falling and breaking a hip, but of course, it could be much, much worse. People can fall and have an injury that immediately results in death or eventually results in death. and I've seen both older people and some much younger people. If you fall and hit your head, it could have just terrible, terrible consequences. So how do we expect the unexpected? So what are we going to tell our caregivers? How are we going to have them support our clients, even if they're not planning on going to the hospital, but especially if they are planning on going to the hospital, maybe because they have a disease that puts them in the hospital very frequently, or maybe because they're having a planned procedure. So how do we expect, how do we prepare? I tell people, pretend you're a Girl Scout. We got to be prepared. People should always talk about and think about hospitalizations and what the challenges are going to be before it happens. You need to know, the client would need to know that hospitalization is a choice, and all medical care is a choice. And I really try to empower my clients and let them know that while the doctors can make suggestions, it's okay to get second opinions, and it is okay to ask for alternatives. And everyone should have a family member. I don't know about you, but I certainly, have friends or family that can act as an advocate for me. I think everybody has that outspoken family member or that friend that they can call on if they need something, and everybody should have that person sort of in their back pocket just in case they need them. And of course, if it is a planned hospitalization, they should make sure and have all their personal information with them, their insurance information, advance directives, medication list, and wonderful stuff like that. So, functional decline we did mention before, and this is the phenomenon that happens when an older person is in the hospital, and it's why it's so terrible for our clients to go to the hospital, because they can have such terrible consequences. Even though the reason they went to the hospital is being cared for, their body is experiencing other changes that can really be detrimental to them when they get home. So several changes can occur as people get older, and that includes reduced muscle strength and reduced oxygen. And if they have other diseases, these problems can be even more significant. So what happens when someone has less muscle or they have less oxygen, they're going to have less physical activity. And this can make people more predisposed to fainting. And of course, if they're not breathing right, this can cause also other problems with their ability to get around and do what they need to do. And all of these problems are now going to contribute to the older person or the client's potential possibility to have this decline during the hospitalization. So a functional decline, which means that they're unable or they're not able to perform the activities that they were in the past, this is something that happens during a hospitalization. And it happens because of all of these problems together. Functional status is determined. How do you determine what their functional status is? It's determined by the ability to perform ADLs and IADLs. ADLs are activities of daily living, bathing, dressing, toileting, and those types of things. IADLs are the activities beyond those, shopping, housekeeping, meal prep, and those types of things. So a functional status is going to be determined by how the client is able to perform their ADLs and their IADLs. 57% of the population is 85 years or older, which is of course our clients, need assistance with at least one ADL. The leading complication of hospitalization in the elderly is a functional decline. So what's our main concern now that a client is hospitalized? Our main concern is that they're going to have a functional decline. They're going to be different now when they get home. We're going to have to talk to the caregiver. We're going to have to change the care plan. We're going to have to possibly refer them for other services, because even though we were providing care before they went to the hospital, and the reason they went to the hospital may have been minor or may have been completely resolved, but now that they come home, they're dealing with a functional decline, which is significantly impacting their status and their needs. There are tremendous hazards of bed rest during a hospitalization, and nobody argues with these. The hazards are immobility, which means they're not walking around enough, accelerated bone loss, dehydration, malnutrition, delirium. Delirium means that they're confused. I always tell my clients in the hospital, because they're always very distressed by this, that it's hard. You're in a hospital. You're not exposed to everyday life. You may not even have a window to look out of. You may not be watching TV. And the days of the week, it can be very confusing. I always joke it's like being in a casino, because you really don't always notice the passing of time the same way as you would in a regular situation. Sensory deprivation, isolation, and shearing forces, which means that they're having problems with their skin now because they're being moved in and out of the bed in a way. Because they have decreased muscle, now someone is helping them get out of the bed, but when you pull someone in the bed, it can cause shearing, which of course can cause ulcers. And then incontinence. And incontinence during a hospitalization can be caused by many things. It could be caused by the disease that they're treating. It could be caused by weakness. They can't even get out of the bed to go to the bathroom. It could be, even though they can get out of the bed to go to the bathroom, that there's no one to help them or that they don't come fast enough. So these problems really can happen to anybody. Bed rest results in a reduction of exercise due to several changes. So when someone lies in a bed for too long, their muscles don't work the same, and it doesn't take a long time for this to happen. Their blood flow is going to be different. They're going to have bone loss, and all of these things can lead to a higher risk of injury to other problems. Of course, a client can go into the hospital for one problem and develop a new problem. We have clients that fall while they're in the hospital, and of course that will present even new challenges and new problems that we need to deal with. Deconditioning, which is when their muscle mass becomes less as a result of a hospitalization. This is going to contribute now to their overall weakness. So the functional decline can occur as a consequence, as a result of these changes, and now they're going to result in the inability for the client to perform the usual ADLs. The client is coming home now. They may be a new client for us, or they may be an existing client for us. The caregiver is going to, or the nurse is going to say to the client, what kind of things do you need help with? And they're going to say, well, before I went to the hospital, I did this, this, and this. And we really need to take a strong look at what changes have occurred during the hospitalization. Sometimes the client doesn't even realize, because now they've been hospitalized and things have been done for them. And now that they're home, it can be an extremely stressful environment, because where they thought they were coming home to be independent or to be mostly independent, now they have these deficits that they absolutely didn't expect or didn't even know they were going to have. And that goes the same for the family members. So we really need to be supportive of the family, because the client, let's say the client went to the hospital for a hip fracture and she was previously completely independent. And now she comes home and she's weak and she's a little incontinent. So now, who's doing the shopping? So the client says, oh, I do the shopping. But really, in truth, she did the shopping, but she can no longer do the shopping. And we, as a team, need to make these suggestions for things that we can help them with and we can offer by saying, maybe for the first week we can order in groceries. These are the services that we use. Would you like us to set it up for them? Or we need to make the family aware that even though their mom was previously independent, we can't depend on that to be the current status. And we need to, of course, reassure the clients and the family members that hopefully these declines are only temporary, but we need to be prepared to offer solutions for the needs that they have right now, and of course, hopefully they'll get better in the future. So staying in the hospital does present certain dangers, and that's, of course, one of the reasons why we want to keep our clients and ourselves out of the hospital. Bed rest is very common. What do people do in the hospital? They lie in bed. Deconditioning and functional decline can occur as soon as day 2. So if a client is in the hospital for 2 days, that's enough to represent a significant change in their status. Studies have found that between day 2 and discharge, so let's say they leave on day 6, so between day 2 and day 6, 67% of those studies demonstrated no improvement. So they've had a decline. They have not improved. And 10% of those experienced a further decline. So while the time that the people are hospitalized has shortened, there is a potential positive side effect. So because functional decline is such a serious concern for our clients and for our loved ones who are in the hospital, getting them out of the hospital sooner can actually, while it presents certain challenges because they are coming home sicker, it does give us a certain ability to stop or to halt those dangers that are occurring while the client is in the hospital. Another study that I looked at showed that patients who stayed in bed didn't always get physical therapy. It's almost like they weren't being addressed because they were in bed. And 60% of bed rest episodes, there was no documented medical indication for limiting mobility status. So even though the client now has been in bed, more than half of these clients, of these patients in the hospital, had no order by the doctor that said you must stay in bed. So really, they shouldn't have been staying in bed, but nobody was getting them out of bed. And that's why this can be so significant. So how do we manage them? The dangers say that people are dying in hospitals from mistakes, from infections, and from accidents. So there are some tricks. They say don't schedule elective surgery for July or August because medical students start in July and August, and fatalities from errors actually do increase during these months. So everyone should know, don't schedule elective surgeries for the summer. Also, we don't want to have surgeries on weekends because while the person doing the surgery may be competent, the staff may be decreased on weekends, or they might be just plain old tired because it is a weekend. Part of being an educated consumer is talking to your doctor about the risks and how to manage them, maybe even suggesting an antibiotic before surgery in order to reduce the risk of infection. Some of the dangers that can happen during a hospitalization include the problems with urinary catheters. There are huge advantages to being on a urinary catheter, and the reason why the doctors do it and the hospitals do it are valid. But as a consumer, it is reasonable to make a request or to ask for an alternative. MRSA is a germ that can live on your skin even if you don't have a current infection. I have heard of nurses who kind of carry it on their skin, which is fine as long as you're healthy. So if you are being hospitalized and you are going to have some type of surgery, you would want to be tested for MRSA before you go to the hospital, because even though you may potentially be living with it in a healthy way, if you now go to the hospital or you have surgery where there's a break in the skin, you could be at risk for getting that infection, and having that information would affect the way the hospital treats you. Another thing is we very often have clients who are in a facility or in a hospital. And why are our caregivers sitting there if they're in a hospital being cared for? And of course, we as caring people know the reason our caregivers are so vital in a hospital or a facility situation is because the hospital just cannot provide all of the care for the client. So in a situation where our caregiver is caring for the client in a hospital where they're not allowed to provide hands-on care, they have a very, very important role where they're going to act as an advocate for the client. And that's the language we use, but it really is quite a significant role because mistakes are made, and it is hard for someone who's ill to speak up for themselves. So part of what we do at Caring People is offering this service and empowering our caregivers to take notes, question things, notify us, and something simple like reminding the hospital staff to wash their hands. While as a hospital nurse, that may annoy me, but if my hands aren't washed, I have no right to be annoyed because I have no right to be touching that patient if I haven't actually washed my hands. And of course, keeping an advocate at the hospital, like I said, a caregiver, a paid caregiver through Caring People really is vital, and it's just such a great service. And in the old days, the hospitals were allowed to say you can't come in unless you're a spouse or a family member, and that rule is no longer available. And then, of course, if the client or the patient needs help, they should call for help. They should not be worrying about whether or not the nurses are busy or they're tired or there's a shift change, and they should call for help, or their caregiver should call for help. All right, so we're almost done. So how do we reduce rehospitalizations? So there are a couple, again, like there is a gold standard for reducing hospitalizations, there is a gold standard for reducing rehospitalizations. Now, the hospitals, this is significant for the hospitals because, as Adina mentioned earlier and I mentioned earlier, everybody, the Center for Medicare and Medicaid specifically, is focusing on rehospitalization. So let me give you a scenario. If I have a urinary tract infection and I go to the hospital and they treat it, I'm admitted for whatever reason, they treat it and they send me home. And they send me home without proper follow-up or without proper medications, and my infection comes back or gets worse, and now I go back to the hospital. So the CMS has determined that the hospital should be responsible, and that my insurance company, if I was on Medicare, should not be responsible because it is, quote unquote, the hospital's fault that I'm going to be rehospitalized. So several years ago, the Center for Medicare and Medicaid determined that they were going to penalize the hospitals. If a patient is hospitalized for the same diagnosis, if they are rehospitalized for the same diagnosis within 30 days of their discharge. So this 30-day number has become quite the magic number for hospitals. From what I've seen, there have been some tricks. If the hospital doesn't admit the patient and then they represent at the ER, I think there are ways to get around it, so we have to be careful, you know, to advocate for the clients. But if a patient is rehospitalized within 30 days, then the hospital is making $0 from the insurance company, which is obviously a significant concern for them. In addition to that, according to the hospital's rehospitalization rate, like their percentage, they are getting fined by Medicare. So this is just really a hot topic. It does trickle down into the Medicare home care agencies. While it doesn't financially affect private care companies, it does affect us because our care is measured, or can be measured, by how well we keep patients out of the hospital. So how do we reduce rehospitalizations? How do we prevent our clients from going back to the hospital? So one of the ways that has been shown is that about the medications. So if a patient comes home from the hospital with medications in their hand, not a prescription, but the actual medications, this can significantly increase their ability to stay compliant and take the meds like they're supposed to. I've seen the hospital sending home patients with a blister pack. That means the pills are on a paper where you just pop them out of a piece of cardboard. This is super organized. There's no stress. Now the person's not coming home and having to figure out which pills to take. Of course, this is easier for our caregivers to help remind them and support them. So it's a really potentially easy thing. Follow-up appointments. So if these follow-up appointments are made in the hospital, our caregivers have to really be supportive and really, really make sure that we're doing everything we need to do to get our clients to these appointments. Because if the appointments are made and they don't do the follow-up, then of course it is not going to have the desired results. And transportation can be a significant problem for our clients, and we do have some options for transportation. So part of managing this particular challenge is just not only knowing and telling the caregiver when the follow-up appointment is, but also making sure that transportation has been arranged. Telehealth is something that is offered by a lot of companies where you use a telephone or you manage someone's symptoms remotely. Home care private home care or through the Medicare should definitely be in place, and it does reduce rehospitalizations. Medication reconciliation means that someone is reviewing the medications that the patient is being given in the hospital, the medications the patient was taking prior to the hospitalization, and the changes, and being responsible to manage those. We all know that when people come out of the hospital, they come out with a big list. They look at this list, they look at the pills that are in their house, and they say, I don't know what to do. This is part of my role, and it's part of something that Jenny and I definitely do when a patient is discharged. Either they were on service before or they're a new client to us. Managing this medication is significant in reducing the rate of rehospitalization. Phone calls from the hospital or phone calls from us can definitely identify things that are going on and things that we can manage in order to reduce that rehospitalization. And definitely, if the client has a new need, like a new insulin, making sure they can actually give themselves the insulin and watching them do it, while it might sound like something smaller and insignificant, is actually a significant tool that we can use to reduce the risk of rehospitalization. And the last thing is that we would focus on the highest risk population. Certain people are at a much higher risk to be rehospitalized. So if you're hospitalized for a hip fracture, your risk for being rehospitalized is not as significant as those with heart failure, which is not only the #1 people are hospitalized, #1 reason people over age 65 are hospitalized, it is also the #1 reason why people are rehospitalized. Certain psychoses, COPD, which would include emphysema and chronic bronchitis, pneumonia, and certain gastrointestinal problems. So those would be the people with medical problems. People who've had surgery on their hip or vascular surgery, they are at the highest risk for rehospitalization. So that is, those are my hints. Those are the ideas and the studies that I was able to come up with. I hope that we can educate and empower our caregivers to really know what to report and know what things they can be supportive with their clients so that we can prevent people going from the hospital and certainly from going back to the hospital. If anybody has any questions, if not, thank you so much for listening and have a great day.
Thank you.